Well, thank you very much, and thank you for this invitation, which I think I got in my role as chair of the Royal College Health and Equality Standing Group. You can imagine what a learning experience this year has been for me. On the 5th of May, which you will remember was the day before the election, I had an interview at the Hull York Medical School for the job I subsequently got. On the 6th, which I accepted that night, and on the 6th of May, of course, the health landscape in England turned round. So I've lived, until the beginning of September, I've lived in Scotland all my life and have worked in Glasgow all my working life. So I feel on a very steep learning curve. Already, though, I can say how impressed I am today by the degree of joined-upness, to use a word that has been very popular in Scottish Government, between the health sector here and the Council. And I think even from the east side of the country, that people will look very enviously at that. And I don't think it's possible to overestimate the degree of concern and anxiety that the significant changes are causing within primary care in terms of the future. And those of us interested in health inequalities are concerned that that's one of the topics that may just slip when all the other agendas that are changing. And it's great to be here to see people who are absolutely committed in the face of all that change, when there's many other things on your desks to do today that are much more up the top of the to-do list, that you put aside the time to do this. And I'm very impressed by that. And the college we're very pleased to be asked to be here. So this is, I hope, the college view, but it's kind of my personal view of health inequalities and what we can do and what we need to do more of. A little bit of context first, a wee bit about the roles and responsibilities of GPs in primary care. And I don't make any apology really for saying that I'll be talking mainly about GPs in general practice, because it's what I know about. But obviously their activities do happen within primary care, and they work very much as a team. And then, of course, we need to say something about the challenges and opportunities that we're all facing. And of course, the reason we're here is because we don't accept that inequality is acceptable. And it's quite easy to sign up to that. And there's lots of ways of looking at the inequality that is across Britain. This is just one particular graph I had. Mike's already shown you some others. This shows where Britain's rich and poor live. But let me tell you about a lesson I learned 10 plus years ago. I don't know if you remember when this book was published. Danny Dorling, who's been mentioned earlier, is one of the authors on it. But what was different about this, I mean, there had been lots of work done demonstrating inequalities, but to my knowledge, this was the first work that looked at it by parliamentary constituencies. So it just gave it a different sort of flavour. So instead of talking about areas, it actually talked about constituency names. And to pick out one of his graphs, this was premature death, i.e. death before the age of 65 in men in the early 90s. And at this point in time, I had just a year before gone to be a GP in Glasgow Shettleston. So you can imagine when this came out, and there's so many, as you will know, I'm sure it was the same around here, there's lots of historic reasons why constituencies get special names, and they don't always actually reflect exactly where they are. Shettleston itself is quite a small area that's got a real identity at the edge of this constituency. And it's now called Glasgow East anyway. So, of course, what did the media do? They thought, Shettleston Health Centre, that's where we need to go and get a view about this report. And there was lots of tables that put Shettleston just there. What was most interesting was the response of our patients and our staff, many of whom, of course, had grown up and lived locally. But the response was, let them go to somewhere really bad. And I thought that, and admittedly, the health centre was on the edge of Shettleston, but it edged with Baillieston, which was number 6. So, I learned, A, people don't always see themselves as others see them, and secondly, how counterproductive labelling can be to a group of individuals and to a place. And Glasgow Shettleston certainly hasn't really quite recovered from the labelling it got, and I think Glasgow East is a much more helpful name for when things are done in this way by constituency. But I learnt very early on that a holistic approach also needs to take understanding where people are and how they view themselves. And if you don't understand that, you can't begin to engage with them in any way. Now, as someone's just said, Cheshire East is not in that list that was in at the bottom of that list or the top of that list that was in the Shaw et al. Book. but even in a place here, and you've demonstrated your interest, there are inequalities. So the people in the most deprived quintile around here do die several years earlier than those in the most affluent quintile. And it does seem a really, I think people do accept that the world will forever be a bit of an unequal place, and there are lots of reasons for that. But I taught, when I was in Glasgow, I taught a module in our master's course on social justice. And I used to say to the students every year, you're sitting here in the West End of Glasgow, and you can drive 10 minutes, if it's not at rush hour, you can drive 10 minutes to one of the healthiest places in Britain. You can direct your car about another 90 degrees in a different direction from the place you start. Another 10 minutes, you can get yourself into one of the most unhealthy places with the worst outcomes in Britain. And that degree of inequality, so close together, just seems completely extraordinary and unacceptable. But you have to remember that health is just part of the social determinants, or health care is just a small part of the social determinants. And most of the public health and social commentators would put health care as quite small. And there is a tendency, I think, for us to concentrate on health care because it's something we can do something about. We can reorganise our services. We can make our GPs provide better care or different types of services. Whereas some of the other stuff, the working conditions, the employment and so on, are so much harder as we're currently finding. That's not to say that I don't think it's important. I absolutely do, but we do have to see it in its wider context, and there's lots of other models that different people have done that are similar. And there's been a wealth, really, of UK response to inequalities, and this is old stuff, and you know all about it. And I'll really just not spend any very long time, but really going back to the Black Report in 1980, which of course really didn't see the light of day. But then Aitchison in 98, and the government did respond to that in various ways with public service agreements and spearhead areas and so on. But to move on to think about what GPs can do. The first thing I really want to just think about is about GPs and individuals. Because in lots of ways, this is what GPs are comfortable with. And I must have passed over a slide there, that when I talk about the roles and responsibilities of GPs, I'll talk first of all about individual patients, because I think that is what they're comfortable with. A little bit about the public health aspect. And then partnership with other agencies and advocacy, both of which I think are harder and not done so well from primary care, but very important. So about the key, I think, and it goes back to that lesson from the widening gap, is that GPs understand the context, or can, if working well with patients, can understand the context of someone's life and how that will influence not only the consultation, but their effect on their lives. And of course, the really hard thing is, not only are socioeconomically deprived people disadvantaged to start with, they're doubly disadvantaged because when ill health strikes, the impact of that is often very different. So, for example, I was speaking to someone earlier about a patient I remember who had a heart attack in his late 40s, who'd previously worked as a labourer for the Parks Department in the council. And although he made a reasonable recovery, the BUPA, who did the occupational health for the council in Glasgow, decided he wasn't fit for his job. But the council said they couldn't redeploy him, and so he was unemployed at the age of 48. I'm not sure how much understanding there was yesterday of that man in the benefits review, and of how difficult a position a man like him finds himself in. Whereas had he been a teacher or a doctor or an office worker or lots of other things, after a period of rehabilitation, he would have got back to work. So the context of people's lives and the way that illness will affect them is hugely important. But of course, the basis of healthcare is good clinical care, as someone's already said, and ensuring that everybody has access to good clinical care, that it involves thinking about the sorts of things that might go wrong in the future, and that it's a whole person approach. So it's not a reactive to necessarily to the current situation. And that requires GPs and practices to think about the structure that they operate in, the structures of their appointment systems. You know, so for example, some practices may hold back lots of appointments if that's what the local population, if the local population need lots of appointments on the day. But other good examples of good clinical care, you know, nutritional care in pregnancy, how important is that? The more I think about these things, the more convinced I am about the early years and how important getting that right is. Looking at screening uptake in deprived areas is less than affluent areas, referral to appropriate services, looking at rates of referral for key conditions, are these appropriate? Looking at rates of patients presenting to A&E, immunisation, and risk factor management, all these sorts of things.